Hello everyone. In today's journal reading, we will see the staged island flap for thumb injuries. It was published in the Journal of Hand Surgery in 1990. Authors are Professor R. Venkataswamy and T.C. Gnanasekharan. Introduction. Good sensory skin cover is of importance in thumb injuries. Several flaps have been described for the same, and each have its own indications, advantages, and disadvantages. The staged island flap was devised in 1977 as a simple and safe way to provide good functional skin cover even by the junior surgeons. Method. The first stage, a neurovascular island flap from the middle finger is raised and made to cover the raw area on the thumb after tagging one of the digital nerves of the thumb. Second stage, the pedicle is divided and the nerve is sutured to the digital nerve of the thumb. Indication in terminal losses of the thumb with skin loss extending onto both the dorsal and volar aspect of the thumb for a few millimeters. The figure shows the traumatic amputation of the right thumb at the level of the neck of the proximal phalanx. Technique. First stage. One of the digital nerves to the thumb, preferably the one on the ulnar side, is tagged with an 8-0 nylon stitch for later identification. After debriding the thumb wound, a pattern of the defect is made, which is transferred to the radial side of the middle finger. Middle segment of the middle finger is used. For larger flap, the flap is extended proximally. We can go safely to the midline both on the palm and dorsum of the finger. The incision is made up to the subcutaneous tissue all around. Palmar incision deepened and flap raised towards the neurovascular bundle superficial to the flexor sheath. Once the neurovascular bundle is seen, the distal incision is deepened and the neurovascular bundle is divided. The flap is then raised from the dorsal side. Three sides are freed. Proximal incision is deepened and raised, taking care of the neurovascular pedicle, which is defined and dissected for a few millimeters proximally. The donor defect is covered with a thick split skin graft. The middle finger is flexed with the MP joint in 60 to 70 degree of flexion and PIP joint in 40 to 50 degree of flexion. Thumb is made to come near the middle finger. The flap is placed over the defect and sutured. Pedicle is covered with split skin covering the donor side or by tubing a small amount of proximal skin flap around it. Hand is immobilized with the wrist in neutral position by a dorsal plaster slab. The remaining fingers are actively mobilized on the day after operation. The graft is inspected on the 5th day. Sutures removed between 8th and 10th days. Thereafter, the splint is discarded. Figure 2 shows an island flap being raised from the radial side of the middle finger. This will be swung around to cover the end of the thumb. Figure 3 shows the island flap covering the thumb before the second stage. After 2 or 3 weeks, the tagged digital nerve is identified and the terminal end trimmed under magnification. The neurovascular pedicle of the flap is divided after developing a few millimeters of the donor digital nerve. Nerve ends are approximated under microscope with 10-0 sutures by the senior surgeon. Skin sutures are removed after 8 days. The flap settles well by the period of 3 weeks. Good sensory recovery is obtained and the thumb is fully functional by 10 to 12 weeks. These are the data collected. Table 1 shows the level of injury in the thumb. Tip of the thumb was seen in 19 patients. Proximal to the tip and through the distal phalanx seen in 30 patients. Through IP joint 10 patients. Through proximal phalanx 5 patients. 63 of the patients were male and 1 female. Age 1 to 10 years, 2, 11 to 20 years, 19 patients, 21 to 30 years 17, 31 to 40 12, 41 to 50 10, above 51 4 patients. Nature of injury: crush was the most common nature in 56 patients, sharp injury in 7 patients, avulsion injury in 1 patient. The figure 5 shows the appearance of the flap a few weeks later, and figure 6 shows the pinch after 6 months. So 64 flaps were performed in 12 years. Most of these were for amputation of the thumb distal to the IP joint. The youngest in the series is 4 years old and the oldest was 60. 38 of them were in the younger age group. Most of the injuries were due to crushing forces in industry. The middle finger was chosen as it can provide more flap. Radial side was chosen for the ease with which both middle finger and the thumb tip lie close to each other. 14 flaps were raised from the ulnar side. Sensation over the pulp on the donor side of the middle finger initially becomes dull, but in more than 70% the sensation improves in a year's time. 75% of the patients had good sensory recovery in 3 months. The average static 2-point discrimination is 4 to 6 mm in 56%, 7 to 10 mm in 33%, and more than 10 mm in 11% of cases. The complications: 2 flaps were lost, one in first stage due to spasm of the vessel which refused to be relieved, other was after the second stage and they cannot explain it. 4 cases developed mild flexion contractures of the donor finger which could be released fully and skin grafted. Discussion: it is technically simple and safe flap. It provides good primary skin cover. Sensory orientation achieved is the best possible since there is no alteration of the pathways of cortical representation as in Littler's island flap. There is no need for sensory re-education. Dissection stops well within the donor finger. There are no scars in the palm or any other part of the thumb. Second stage nerve repair is performed by a senior surgeon. Flap is ideally suited for the terminal amputations of the thumb, including cases where the loss extends for a small distance on the dorsal or palmar aspect. Thank you.